In our mid 30s, we start to lose testosterone. That's low libido. Executive function thinking goes to hell in a handbasket. We get depressed, moody, anxious, panic attacks. So we want to replace testosterone.
Welcome to Wellness, your ultimate guide to unlocking your full human potential through biohacking. I'm your host, Ashley Deeley. I'm a certified sports nutrition coach with a degree in kinesiology, and I'm a former personal trainer and Pilates instructor. If you're listening on YouTube, hit subscribe. If you're listening on Spotify, open the app and give me 5 stars. Or if you're listening anywhere else, a review means so much as it helps listeners just like you find this hidden health information faster. Did you know red wine doesn't actually stain your teeth? It's the artificial dyes they add to the wine. But that's not the case with Dry Farm Wines. This is an exclusive wine club which brings you natural, organic wine sourced from farms across Europe who practice regenerative farming. All wines, like this one, are completely sugar-free and fully fermented with less than 1 gram of sugar per liter. Plus, their wines are under 12.5% alcohol, which means you can enjoy your wine without any artificial dyes, preservatives, or sugar. Because you're a loyal listener of Welcome to Wellness, you'll get an extra bottle for just 1 penny on your first order. That's just 1 penny for a beautiful, natural, organic wine. Visit dryfarmwines.com/Ashley Deeley. What if I told you there was a supplement which could help you burn fat, improve energy, maintain muscle mass, and optimize your thyroid, all without any negative side effects? Would you take it? I do. It's a supplement called Thyroid Fixer, specifically T2. T2 boosts your metabolism so you can finally shed those stubborn pounds, and it helps regulate your insulin and glucose. You can use Thyroid Fixer whether or not you have a thyroid condition, and it's safe to use for both men and women. Thyroid Fixer is a supplement I take every morning. It's a no-brainer. Visit betterlifedoctor.com/Ashley and use code WELCOMEWELLNESS to get started. Today's guest is Dr. Angela DeRosa, returning for the second time. Dr. DeRosa is dedicated to transforming women's health and wellness, especially concerning hormonal balance and all things perimenopause and menopause. Having experienced early menopause herself at 35, Dr. DeRosa realized the significant gaps in women's health, understanding, and treatment. This personal journey fueled her passion, leading her to specialize in women's health, even developing one of the nation's first women's health programs during her residency. With over 20 years of experience, Dr. DeRosa has worked to improve women's access to proper care. She founded Dr. DeRosa Medical in Arizona, attracting patients worldwide. She's a frequent speaker and author of the book, How Your Doctor is Slowly Killing You, a women's health survival guide. Dr. DeRosa is committed to empowering women and revolutionizing the medical paradigm for healthier, happier lives. Dr. D, welcome back to the show.
Oh, thank you. It's so delightful to be back. I so enjoyed our conversation the last time. You had such great questions, and I'm sure your audience was thrilled at the information you were able to pry out of me, which was
Yes,
actually
I
pretty
did.
easy.
Yes. Well, that's why I had to have you back on because I had so many questions. So, one of the questions I wanted to start with, which we never got to last time, was your personal story.
Oh, sure. It was really, I always describe it as a collision of my professional life and my personal life. And it really started when I was in my latter years of medical school and early into my residency, where I started noticing some really strange things that just didn't seem right for my personality or my body. Because I was considered myself a very healthy person, in particular then, that was many, many years ago. And I started having some panic attacks that I never expected, anxiety. I just was starting not to really care about things like I normally did. So that moodiness, and everyone kind of attributed to, you're under stress, you're in medical school residency, you're not sleeping. So it was kind of understandable. I was newly married, but didn't have any sexual desire or libido at the time, and loved my husband. And we were young, and we should have had the time of our lives. And also, I started having hot flashes, night sweats. I was starting to put on weight, and I just didn't feel like myself. And what became the most alarming is I started to experience heart palpitations, and also kind of to the point where my heart would race so much that I would pass out whenever I was starting to work out, like on a treadmill or various other things. And that prompted me to start seeing cardiologists and endocrinologists and all the ologists in the book. And here I am, a resident at the time, undergoing this evaluation, smack dab in the middle of the profession, seeing colleagues who were friends of mine, and nobody could help explain to me what was going on. And in fact, I was dismissed completely, just saying, oh, there, sweetheart, go on a date night with your husband, eat better, exercise more. And, oh, by the way, try to get some sleep, even though you're a resident. And it was absurd what I was being told. And I was also being put on medications to control some of the symptoms. I was put on beta blockers to slow my heart. I was put on an antidepressant to obviously deal with the mood issues, and a whole host of other things just to try to treat symptoms of what was going on with me. And after $1 million workup and all these medications, I never felt any better. And in fact, I felt worse. And it wasn't until years going by after that, of suffering through all that, that in hindsight we looked back, and I ended up learning more and more about hormones and how women's health and hormones interplay. And I was being trained as an internal medicine doctor, and females were coming to me in droves because I was a fellow female and there wasn't many internists at the time. But I wanted to learn everything I could about women's health care and then hormones and various things. And it wasn't really until hindsight realizing, when I went through menopause at 35, I knew I was in perimenopause at that time. But instead of being treated properly and given the proper hormone balance that I needed and my body was craving, I was basically drugged and dismissed. And I vowed that from that point forward, I was never going to allow a patient in my care to be treated that way. And I was going to focus my whole entire career on understanding women in particular, although I treat men, and men are fabulous to treat and a ton of fun. But that we needed to learn not only how hormones affect our quality of life, but also how they prevent chronic illness. And I'm just got invited to my 30-year medical class reunion, and I can't believe it's been 30 years. It makes me feel so old. But for 30 years, this has been my passion and what I do. And it's mission driven because of my personal crisis. So you asked, it's a
I
long drawn out
did.
story.
But thank you for sharing that, because I feel like so often women go through these changes at different stages. And if we
Yes.
can help one person, if there's some 25-year-old out there,
Mhm.
someone in their 20s feeling the same symptoms you are,
Yeah.
then they can find a little bit of light.
Well, and that's what's so alarming to me is patients get told all the time by the medical profession, oh, you're too young to have hormonal imbalances. And 10-15% of us are genetically programmed to have premature ovarian failure before 40. And oftentimes, things we do to patients, like antidepressants or birth control pills, can cause hormone imbalances in very young teenage girls and 20-year-olds. So we should no longer use that statement, because, yes, indeed, women can have hormonal imbalances and they can happen very, very young. And even in a natural progression of decline of the ovary, most women start the hormone deficiency symptoms in their mid 30s. And it's so interesting is I have an assistant who helps me out and makes my life so much easier. She was just here and she's smack dab in the throes of perimenopause. She's just
Oh,
having a hell of a time with it. And she said, if one more woman or one more person tells me I'm too young, and she's 48 years old, she said, if they tell me I'm too young, I think I'm going to punch them. And she's like, she's struggling with the coping stuff right now. So we're trying to get her
oh.
hormonally imbalanced back
Well,
to
I
normal.
have to know, your story's so captivating, but how did you connect the dots? How did you realize you were hormonally imbalanced?
Well, it was interesting because you know how the universe pushes you in directions that you need to go. And as I started learning more and more about hormones, I became come across very, very influential mentors in my life. And also, what was really probably one of the greatest things that occurred was 2 years out of my residency, I was invited to become the medical director of Procter and Gamble, for in charge of a female kind of sexual health and osteoporosis line. And they had just newly gotten into pharmaceuticals. They needed 8 medical directors. I was sitting on one of their medical advisory boards because of all the work I was doing in women's health. And when I decided to make that leap from clinical over to the big pharma dark side of medicine, and mind you, I kept seeing patients. They allowed us as medical doctors to see patients 1 day a week throughout that time. But for 8 years, I went over to Procter and Gamble, and I then got the opportunity to learn from all the international experts in female sexual health, hormonal health, osteoporosis, bone health. For 8 years, I basically went across the globe and learned from everybody I possibly could, and from their expertise, coupling it with my symptoms and what I was going through, and then also with my experience with my patients. It just became so obvious. And then I started developing protocols and how to then teach others so that we can continue to train folks. Because the alarming thing that everyone should be really worried about, since the Women's Health Initiative in 2002, physicians stopped getting trained on menopausal care. So we have generations of doctors who are out there that don't have a clue how to manage
Yes.
patients at all. Mm-hmm.
Yes. Heart palpitations really caught
Mm.
my interest because recently my mom, who's 65, said that she
Mm.
was experiencing heart palpitations
Yeah.
and her doctor wants to put her on statins. And I said, talk,
No,
let's talk
stop.
hormones first.
Stop the
So,
madness.
so can you walk me through the importance of what hormones can do for the heart?
Yeah, so it's interesting is that what I was seeing a lot in my particular case, and this will hopefully help women understand theirs if they're experiencing it. When estrogen levels drop, our myocardium, which is the heart muscle, becomes irritable, and it really doesn't, just like everything else in our body, and it makes it more susceptible to kind of what we would call PVCs or skipped beats or various other things. In my case, it was becoming so significant, it was causing runs of runs of these PVCs that were actually causing me to pass out because it was becoming quite significant. Now, you could see this in women too, younger, when they have cyclic drops in their estrogen. So a couple days before you have your period, you have decent levels of estrogen and progesterone. Then the egg dies, or actually where the egg comes out of, it's called the corpus luteum. That complex dies, and it has a programmed cell life of 14 days. You ovulate, it has 14 days, and then it dies. And then what happens is your estrogen and progesterone levels plummet like a rock. And it goes close to zero on estrogen and progesterone the day you start your period or the day before. So you can be very, very low during your period on estrogen. And that's when most women, if they're sensitive to that, their heart can start to have those palpitations just during their period or the day before when their levels are at their lowest. But as then women progress through perimenopause and their estrogen levels drop on a day-to-day basis, they can have those experiences more frequently. And it's one of the most commonly reported estrogen deficiency symptoms in women. But what ends up happening is they get these huge cardiac workups. They get thrown on beta blockers or stuff like I was put on. Or if, oh, by the way, during that time, their cholesterol goes up because estrogen deficiency leads to abnormal cholesterol patterns. Then they get put on a statin, which, oh, by the way, messes up your hormones because all hormones get started from cholesterol. So it's like people need to think about root cause and what we're driving when we do these things, and it makes the whole situation worse. But I want to caveat though that not all women have hormone deficiency induced palpitations and heart problems. Certainly we have to be cognizant of the risks and making sure that we do the EKGs and make sure but if you have an otherwise normally healthy young woman coming in, I'm not going to go looking for zebras when the horse is sitting right there in the barn. So,
Good point. This is a good point. Okay,
yeah.
so I want to dive in a little bit more. I know last time we talked about the top three hormones: estrogen,
Mm-hmm.
progesterone, testosterone. I wanted to ask you a question, but I wanted to share a story first before I
Oh, please
ask it.
do. Yeah.
So I know that there's hundreds of symptoms associated with perimenopause, and one of them is itchy ears. And I feel like I will just be like itching in my ears for days. And so it probably wasn't the best thing to do, but I thought with my topical estrogen that maybe if I took more of it, I could get rid of these symptoms. So I started taking maybe 3 or 4 or 5 times the dose. I don't know. I was just pouring it on my arm.
Oh, no.
And then I only had a 23-day cycle. And I thought I was doing a good thing trying to make my
Yeah.
symptoms go away, but then I realized maybe I overdid it. So, can you walk me through the balance between estrogen and progesterone and when we should be taking them?
Yeah, so first off, women are so funny in how we experiment on ourselves all the time, and I'm guilty of this too. But actually, itchy ears, dry nasal passages, allergies, all these, even dry skin, burnt mouth syndrome. There's a whole host of weird things that can start occurring when you become hormonally imbalanced, and even to the point where sometimes even putting like an estriol cream in the eardrum can actually be, but it should be very,
Oh,
very low dose. But obviously the
okay.
goal is to try to fix the systemic issues versus trying to deal with local areas. But sometimes that can be very, very helpful. But also be careful that because there can be psoriasis or seborrhea, other things unrelated to hormones that can lead those kinds of symptoms. So before you starting to put estradiol or estriol in your ear, you may want to just look at that. Although you could do a trial, a very low dose of estriol and a Q-tip and try that. But I know a lot of ENTs don't even like us to put Q-tips in our ears, but I digress. So as we discussed, just for clarification, since some of you may not have listened to our first talk, but peri means the time around menopause. So the time leading up to menopause. Menopause is an absolute point in time where the ovary shuts down, and then everything after that is postmenopause. But in the perimenopausal time frame, when your hormones are starting to become erratic or imbalanced, you want to, when we treat those patients, we want to rebalance or normalize. So, number one, in our mid 30s, we start with the testosterone decline. That's the low libido, the executive function thinking that goes to hell in a handbasket, the coping mechanism. So we get depressed, moody, anxious, panic attacks. It helps with muscle energy and it helps with our not fatigue. It helps us cope. It helps with libido. It does all kinds of wonderful things, prevent migraine, headaches, help us with weight control. So we want to replace testosterone when that comes to be insufficient. And usually we become deficient mid 30s. Now, as we move into the 40s, that's where usually the estrogen and progesterone kind of things start to happen. And usually it's the estrogen deficiency that starts first, where our ovaries just don't make enough estrogen. And then as we get closer and closer to menopause, so the year or two, our periods may become erratic, which now the progesterone is completely misplaced in the wrong spot. So what happens when we have our period, it sends a signal, a hormone sends a signal to the brain, says, okay, we need to go make more estrogen. We're going to start this whole cycle over. So progesterone, the first 14 days is non-existent or very, very, very low. But estrogen starts to climb up the hill till it gets to its highest point in women mid-cycle. And when it hits a certain trigger point, we had another hormone comes out and then we ovulate. When we ovulate on the ovary, it has a scar tissue. It's called a corpus luteum. That scar tissue starts to secrete progesterone. So after we ovulate, our progesterone levels go really, really high. And so they kind of hang out there until the corpus luteum and the egg dies. And then all of a sudden everything drops and it starts the whole cycle back over. And it's supposed to stay even. But as our ovaries start to fail, imagine the ovary may take 5 months for it to drive up the hill to get to the set point to cause ovulation. So what happens during that time frame is you don't ovulate, so you don't get your period. You're going to have a lot of estrogen around that you don't need, that doesn't get relieved. So you may get breast tenderness, bloating. You may have kind of swelling of the extremities. But then let's say it takes 5 months and you ovulate. Those 14-day goes by, I'm going to tell you your PMS is going to be pretty lousy. And then when you bleed, you've now had 5 months of bleed of uterine lining building up that whole time. And then you're going to have a heavy period, usually with clots. So when we start to see that, when that lining continues to grow, we can put us at risk for uterine cancer. So what we want to do is kind of reset that. So if women are becoming highly anovulatory or not having their periods, I can use progesterone 2 weeks out of the month, corresponding to days 14 and 28, to reinduce that cycle so that they have those bleed off. So it becomes a balance of giving them a little bit of estrogen to deal with some of the estrogen deficiency and helping them cycle with the progesterone. So now if you introduce too much progesterone or estrogen, sometimes if it's way too much, the body's not going to send any signals to the brain to do this whole cycle the way it should. So that's why we need to be very careful with hormones and how much we're dosing, because you can almost create levels like a birth control pill, which you don't get anything happening whatsoever. Or if in your case, you just may make it erratic and, and different.
Oh,
So
okay.
that's perimenopause. Now in postmenopausal women, if we give women estrogen, estrogen is going to cause the uterine lining to grow. And that's what it's supposed to do. But if you're not having periods once a month to clean house per se, that's going to continue to grow, and lead to potentially uterine cancer. And if you start estrogens without progesterone in women with a uterus, there's a one third chance, so 33%, that you could develop uterine cancer over 10 years. So we don't want that to happen, obviously. So we give progesterone to balance it, so that the progesterone kind of says, okay, yeah, estrogen, you're not going to go too crazy, and we're just going to let you grow it a little bit, but not a whole lot. And so we have to use it in women with a uterus. Now, if a woman doesn't have a uterus, you're not obligated to give progesterone to patients. But there are some school of thought that believe it helps with breast health, helps with overall well-being. It definitely helps with sleep at night. So I can give lower doses of progesterone if I need to in women without a uterus. So it's a very complex topic, and most physicians even struggle with it. But hopefully folks got some tidbits out of there.
Yes. Well, this is why I wanted to have you back on the show, because I feel like a big portion of my show is hormones. And I felt a bit silly that I gave myself a 23-day cycle by using too much
Yeah.
estrogen.
Yeah.
But now I'm curious to learn, if we go 4 or 5 months, like you said, in between
Mhm.
periods, when would we take progesterone if we have that long time in between?
So in my protocols teach, if the periods are coming, let's say every 1 to 3 months, that's enough of a slough off once a year, that, or 4 times a year, that you're not going to be at risk for uterine cancer. So the data shows that as long as you're getting a period at least 4 times a year, the risk of uterine cancer is very, very low. So how I do it is, if a patient gets to longer than 3 months on average, I need to do something. So, and how I do it depends on how long you're going in between your periods. So if you're going between, say, 3 and 6 months on average, I'm going to work with Mother Nature and cycle you. So I'm going to do the progesterone days 14 to 28 days. But if you become to the point where you're not having periods on average longer than 6 months, that's a good time where you can just start progesterone at bedtime nightly, because the ovaries are kind of tired out enough that I can start it at bedtime and not try to cycle a patient, and they usually do just fine. So
Oh, okay. That's really
yeah,
helpful.
yeah.
And I think I wanted to ask you this question from last time. I wrote it down when I re listened to the episode, but I think it was the protocol for how much progesterone. Is it anywhere between 50 to 100? Can we overdo it?
Yes, you can, because too much progesterone is bad too. Because if you overdo it on progesterone, number one, they can get sleepy. It's almost like a sleeping pill. I swear, you can take it at bedtime. Most women are out within 15-20 minutes, and that's a standard 100 milligram dose. Now, some women, however, they can be really sensitive to it, and they'll wake up feeling really groggy. If you give too much progesterone, it can lead to weight gain. It can lead to depression and moodiness. It can lead to fatigue. It can also lead to uterine bleeding and spotting, believe it or not. So you have to not give too much. Now, the key is to find what's going to be safe for that patient. So if it's a postmenopausal woman and I'm giving estrogen, the minimum dose I can give is 100 milligrams to protect that uterus from having too much growth. So a lot of practitioners will just keep doubling doses and doses and doses and go really, really high. But usually I like to max out around 200 milligrams. And if it goes higher than that, women typically will get side effects. Now, I do have some women that are above that, and that's a special circumstance. But most often you want to be around 100 postmenopausally, maybe up to 200 milligrams. And now, if they don't have a uterus, I can use 25 or 50 milligrams safely, because I don't have to worry about protecting the uterus. And sometimes that's enough to help with their sleep and some of the other stuff. But perimenopausally, as long as they're having regular cycles, if I'm using progesterone for sleep or anxiety, I would start with very, very low doses. But my whole protocols start anywhere from 25 milligrams, typically up to 200. But I have colleagues who go 3, 4, 1200, which I think is excessive.
Oh, okay. The practitioner that I'm working with, I think, could use a bit of help. And she's told me to take progesterone on days 14 to 25, but everything I've read and other people I've interviewed say 14 to 28. So does it make a difference?
Honestly, those 3 days probably don't make that big of a difference. But if you want to mimic the cycle, you're going to do it 14 to 28 days. So I'm not sure where they got 25 because that doesn't make
This
biological sense to me. But from an overall, the ultimate outcome is going to be, it probably doesn't matter that much. But some women are exquisitely sensitive, and that's where you'd have to work through that.
okay. I also wanted to ask you about the ideal test ranges for hormones because, as much as I have my own podcast and try to share this information, my mom went and saw someone and she said, "Oh, my levels were fine." And I said, "They're fine for an aging woman. You want to have
Exactly.
optimal levels." So, can you walk us through what
Oh,
kind of
girl.
labs you'd like to see?
Well, you're absolutely right. And it's important that people understand that those reference ranges are just that. They're a range, and not everybody falls into a range. So let's say if I have one woman come in with one value and the other have another, the same exact value, one could be symptomatic, the other isn't. So you have to first off take the patient at face value and not try to stick them in a range. But you're absolutely right. When we create reference ranges for patients in the labs, what they do is they go out and they measure a whole bunch of people, and then they say, this is the average of this population, so that must be normal. But if you're comparing your normal to, say, sick elderly people, you're going to say, well, being sick and elderly is considered average, but so it must be normal. Well, of course, your hormones are going to be down when your ovaries fail at 60. They're consistent with someone who's 60 years old and aged. It doesn't mean that's normally healthy levels, which you would see in optimal young patients. So you always have to be careful to ask who you're comparing it to. Do you want to be the same as other 60-year-olds, or do you want to have the health and youth and vitality and hormonal balance of someone in their 20s? Of course you want the 20s. So be careful of those reference ranges. Also, not all clinicians know how to put the information together, in particular with hormones. So, for instance, a big mistake I see is they'll look just at estradiol levels. And if, let's say, we get an estradiol level of 10, they're going to go, oh my gosh, that's really, really low. You have estrogen deficiency. Well, during a woman's period, they can be really, really low, and that's normal during that time. But if you don't know how to interpret that, you may suggest estrogen deficiency when it's completely normal. On the other hand, too, you could, around our mid-cycle ovulation, estrogen levels could be as high as 500, 600. But if you have someone who doesn't know that, they'll go, oh my gosh, you have estrogen excess or estrogen dominance. We need to do something about this and put you on a whole bunch of progesterone. And then you're going to feel really lousy because you're on a whole bunch of progesterone. So that could be normal. So there's another hormone called FSH, follicle stimulating hormone, that will tell me if it's normal or not for that patient. So let me go back to the first scenario. Let's say we have two women. Let's say you and I both walk into our doctor's office and our estrogen level is 10. And you and I are both complaining of some estrogen deficiency symptoms, and the doctor looks at it and goes, oh my God, you're horribly deficient to both of us. Well, let's say you have an FSH, which is normal in perimenopausal women at a certain time in their cycle, to be between 5 and 10. So let's say your comes back at estradiol of 10 and an FSH of 5. That tells me that is normal for someone who's having a period. But let's say my levels come back at 5, but my FSH is 100. That means severe estrogen deficiency. I should be in menopause. But if I don't check the FSH level and I look just at the estradiol level, I could misdiagnose one of us. And so it's important that you use the information together and know to do that, where a lot of clinicians don't if they don't study hormones. Now, testosterone, on the other hand, the reference range is very, very arbitrary. The lab that they use for women, it's very, very inaccurate. And again, when you look at testosterone total levels, when we look at them in the blood, it doesn't always mean that's what's getting into the cells either, which is why it's important to ask women about their symptoms. Because we have found with testosterone labs, they do not directly correlate very well symptomatically in women. So it's important to use the testosterone levels as a guide, but really listen to the women and how they're responding to therapy, and also trying to avoid side effects too. So the clinical data is really compelling that those two levels, symptoms and the testosterone levels, don't correlate. But unfortunately, if you walk into a physician's office and say, oh, well, you're in the reference range, but you're sitting there with all the testosterone deficiency symptoms, they may not know what to do with you.
Oh, such good examples. Thank you. Also, have you heard of Dr. Devaki Lindsay Berkson?
Yes.
So I had her on the show, and she said that single digits for your for your FSH is ideal. Do you have thoughts on that?
Well, it depends on, and she's right. And I know Lindsay and I know each other very, very well, and I know that she's actually gone through my training, believe it or not.
Oh,
So when you look at FSH, half of the month in a perimenopausal woman, it's going to be between 5 and 10, and the other half it's going to be 1 to 10. So to her point, if it's under 10, usually it's normal. It depends where in the menstrual cycle. But if it goes over 10, the body's starting to show that the brain is trying to tell us that, yes, the estrogen is becoming deficient in that patient. And the higher that goes, the more deficient the patient's becoming.
okay. Okay, got it. And now, Dr. D, what can we say to our doctors to be prescribed testosterone?
Well, I think it's important that they understand the relevance of in women, and it's been largely relegated as a male hormone, which is so unfortunate. It was actually, I want to say, back in the 30s when they were doing assignments to sex steroid names and various things, and they just assigned, oh, men are men, they have testosterone, so and then women are going to have estradiol, but we both have both hormones. We just have them in different balances. And as we've talked in my last show, that testosterone is actually more abundant in women than estradiol day to day. And it does exactly the same things for men as it does in women, or for women as it does in men. And not all the clinicians understand that or assign its importance. They want to either put it into the category where we don't need it, or we just need it for sex and libido. But it has all those other effects. And the problem is the studies have largely been done in men because they don't want to study women in perimenopause or reproductive years with testosterone. Because if I give women too much testosterone that is above their natural levels, and let's say they get pregnant, you have a potential for virilization of so the female fetus could have male characteristics if they were pregnant. So largely pharmaceutical companies don't study, or NIH people or any of those folks do not like to study reproductive women because God forbid they get pregnant on anything that we're doing to them. They don't want the legal risk. So all of the research have been done on men. But so we have very limited research. But when you look at the clinical effects and you look at indirect sciences and different articles and publications, it's showing the benefit in women. It's just the data is not as plentiful, but it does biologically very similar things in both of us. So I think it's important that and if they don't want to prescribe testosterone or they don't seem to have a clue, then you need to find another doctor, because it is such an important aspect. And it's like a marriage. I always tell my clients it's a marriage, and maybe there's some of you that don't resonate with me. That's okay. But find someone who resonates with you. But if you have a certain mission in mind about hormones, make sure you're going to someone who knows what they're doing and not just either dabbling it or just kind of, oh, okay, you want testosterone, here it is, but I don't know how to manage it. That's ridiculous and insane. They shouldn't be doing that. You should go to someone who knows, okay, oh, you want to do this. I've been trained to do this. I studied this. I'm a specialist in this. I mean, those are the things you're looking for. You just don't want dabblers.
I think that's a really good point.
Because
And a really
otherwise
good.
you're going to be just like you, putting extra estradiol on there trying to treat
I
your ear.
know,
So
right?
it's no
I
better.
know. Or taking progesterone on only days 14 to 25. And I'm like, for all the people I've spoken to, I feel like I know that's not right. So we were speaking about your assistant earlier who said she's going to punch someone.
Face,
I
yeah.
was in I was in Mexico recently on a girls trip, and I feel so thankful that we live in a day and age where we can talk about these things, because
Mhm.
I'm sure my mom never talked about it. And I'm talking with these girls who are telling me, their clots are like as big as a silver dollar, and they're
Yeah,
feeling very dry down there, and
yeah.
they get dry eye. So I'm curious to learn, and I guess I'm going to let you take this anywhere you want, Dr. D, but what are some of the symptoms, even if we think maybe we're too young for these hormonal imbalances?
So if let's break them down between all the hormones. So testosterone, as we've discussed, the migraine headaches start to appear. We just can't retain information. When we're reading a paragraph, it may take 5 or 6 times and then an hour goes by and you forget it. I mean, the executive function thinking goes to just crap. You will start to gain midsection weight gain because you're not going to process sugar anymore, and you may see your blood levels go into a pre-diabetic range because of the testosterone deficiency. You are likely going to be struggling with low libido, lack of desire, or if you do engage in sexual intercourse, that the clitoris is not as sensitive and it may take longer to orgasm, or the orgasms just don't feel as good as they used to. It may become blunted. So men get the erectile dysfunction where we get clitoral insensitivity. So very similar, but just one's more externally noticeable than the other. You're going to see more fatigue. Your muscles are going to start to waste. Working out is going to take longer to have a good workout, or your recovery takes longer, or you're just exhausted afterwards. So there's all these different things that testosterone does that are so important for us. Then you have the estrogen deficiency symptoms. The hot flashes, night sweats, very common. Vaginal dryness, to the point when some women say that it feels like a knife is stabbing them in the vagina, even when they sit down. Can lead to extremely painful sex. Some women say they can't even have anything inserted without bleeding or exquisite pain, and which then negatively impacts their desire to have sex, of course. So it affects intimacy and relationships. But not only does the vagina get dry, so does the nose, which leads to bloody nose, dry nose, more allergies. Our eyes start to dry out, which can lead to corneal curvature changes, which can lead to vision changes. So, I mean, we can get dry mouth. We can have burning mouth syndrome, which can come from that. There's all kinds of things that are related to mucosal membranes. Estrogen deficiency can also lead to fogginess. Estrogen and testosterone deficiency lead to bone loss. Estrogen is so important for our endothelium in the inside of our arteries and veins, so we start to get hardened arteries and our blood pressure starts to go up. It affects dramatically HDL, the good cholesterol starts to lower, which is heart protective. So it's directly impacting our cardiovascular risk. Both hormones are essential for cancer prevention, and believe it or not, breast cancer. I mean, testosterone, the data is very, very solid that it reduces women's risk on getting breast cancer, but if they've already had it, will reduce their recurrence rates. Estrogen does not, estradiol, the bioidentical estrogen, does not cause breast cancer. Despite everything that you've been told, the Women's Health Initiative, that message has been largely refuted now. It is synthetic progestins that potentially could cause an increased risk, but not estradiol. So women need to get that out of their heads. The heart palpitations, the heart arrhythmias, I mean, there's all kinds of things that estrogen affects. Progesterone, when is imbalanced, you may start to show the irregular periods, which is really common in women, or the heavier periods and various other things. So, but one thing I do want to draw to attention, and maybe this could be a third episode down the road, but during perimenopause, I would have to gather about 80% of my patients start to develop low functioning thyroid or overt hypothyroidism. It's just a very common thing in women. And it most often collides when you start to go through perimenopause at the same time, which is like putting gas on a fire, because when your thyroid slows down, it is your engine. So you are going to become tired, you're going to gain weight, you're going to lose your hair, you're going to feel cold all the time, your extremities are going to swell. So if you put all that on top of all those other things, can you imagine how lousy women feel?
Oh,
So it's just not fair what Mother Nature does to us.
no.
So
And it feels like a miracle we've made it this long, and it's only now
oh
becoming
yeah.
something that we talk about mainstream.
Well, our parents, our mothers and grandmothers, they dealt with it with alcohol and Xanax. I mean, I think about all the little old ladies I treated over the years who are just all addicted to their little benzodiazepines. And
Yes.
so it was like, that's how they coped.
Good point. Well, I'm so thankful for your work. I want to go back to what you said about how if we don't have enough estrogen, our good cholesterol can go down.
Yep.
So,
And the
this is,
bad cholesterol goes up too. So,
oh, so
mhm.
are there, I feel like I already know the answer to this question, but are there hormone receptors all over our body?
There are. Absolutely. See, this stuff, but no, this is why it's so funny to me that the medical profession is so focused on treating illness through medication without recognizing all of the impact that these hormones have. And they're almost joked about. And it's like they're made so insignificant, but there's such a foundation for our overall health when you look at all the organ systems that they impact, every single one of them. And so it's just remarkable to me that how well they can be dismissed. But we live in a culture where we have sick medicine, where we treat to sickness. And good news is I'm seeing more and more functional medicine docs, alternative medicine, naturopath, whatever you want to call it. But more and more folks are so frustrated with the current state of affairs in the health system that we've got to do something different and better because what we're doing is clearly not working. So,
Yes.
mm.
Yes. And I do love the idea of having you back on for a third time to talk about thyroid because wasn't it last time you said the three musketeers? It was like
Or the
thyroid.
three musketeers: thyroid, testosterone, and estradiol.
Yes. Okay. Yes. So we'll have you
They,
back on because I know it will take more than 20 minutes to talk about thyroid. But I wanted to go back to heavy periods because when I started learning
mm.
about what perimenopause was, it's along the same time when I heard the term crime scene period. So
That's very descriptive and
so
easy to picture.
and I've spoken to a lot of people in my community about this. What kind of options do we have to maybe mitigate that crime
Yeah.
scene experience?
Well, it's really important to understand what's driving it because there are non-hormonally related things so anatomical things. So imagine if you have a fibroid sitting in there, that's going to be stimulated by the estrogen and then the progesterone when it's secreted. If you're doing it cyclically, you're more likely to have bleeding. And it can be bleeding and spotting, but oftentimes women with fibroids tend to have heavier periods. So it also, if some women say if they have polycystic ovarian syndrome, they may not have as much regular periods, or even with low functioning thyroid, if their periods become not as regular, when they do have a period, it's going to be heavier. So there's many things that need to be addressed when you're talking about heavy periods. Even cervical polyps can lead to heavier periods, but usually those will lead to more intermittent spotting. So, but it's important to make sure that if it's that bad, that you're ruling out other anatomical causes in addition to straight up hormones. But if some women are just genetically programmed to have heavier periods than others. Being overweight puts people at risk for heavier periods because they're storing more estrogens in their fat than and I'm not saying this is all heavy women, but heavier women on average tend to have heavier periods. So some weight loss can tend to help with that as well. But it also becomes this really weird negative feedback cycle because if they have testosterone deficiency, which led to weight, or hypothyroidism that led to weight. So it's important that you may need to balance hormones to give them the opportunity to lose the weight. Otherwise, they're hitting their head against the wall. So it's a very complex issue. But let's say you're struggling with heavy periods. You don't have to struggle with that. A lot of women develop anemias from their periods being so heavy, which can really lead to extreme fatigue and puts that at risk for shortness of breath and cardiovascular diseases because their heart is stressed because they don't have enough oxygen. So you need to take it seriously and watch for those anemias. But first and foremost, you can put women on birth control pills to help with that but birth control pills aren't without negative consequences because all birth control pills are going to cause a 100% testosterone deficiency. So you have to, if you're going to put women on birth controls, they need to make sure they're rebalancing the testosterone piece. So that's one option. a lot of women these days are going for uterine ablations. They go in and they surgically basically fry that uterine lining so the lining is so thin that most often women don't have periods anymore because there's no lining to have a period, or at the very least, it becomes much, much lighter. Another really good option is to throw a progesterone secreting IUD like a Mirena, Kyleena, Liletta, because what that does is deliver progesterone right to that uterine wall, and it just thins out that uterine lining, which can be really, really helpful to lower the amount of blood that comes out during the period. And then you can also remove the uterus, but obviously that's a very extreme step. But for some women, that's the correct option for them at that time. But there are options that you can use for those women.
These are really good ideas. And as you were speaking, it reminded me of one of my friends who said
Mm,
that for a couple months, she was just bleeding nonstop. And so she
mm,
went and saw the doctor who put her on the birth control pill. And she said if it regulated, then the next step would be considering an IUD. I recommended a copper one because this is not my field. But
yeah.
hearing you speak, she's still on the pill, but hearing you speak, it sounds like she needs to take testosterone and maybe consider an IUD with
Yes.
progesterone.
And here's what's interesting about a progesterone IUD is it allows your ovaries to still function normally because it doesn't shut the ovaries down like birth control pills do. So you still get your natural hormonal secretion. Now, is that still depending on your age and other genetic factors enough? You may still need some testosterone depending on your age, but your average 20-year-old girl or woman, excuse me, if she's having heavy periods and goes and wants that Mirena IUD, if there's enough hormonal secretion going on, she may not need anything hormonally. But if she's, let's say, in her 30s, it's likely she still made some testosterone, but she was going to need that regardless if we put the uterine progesterone IUD in, either way. But there, I really love the progesterone IUD because it just delivers that progesterone right there locally into the uterine wall. It's very safe and it doesn't systemically absorb and mess up all of your hormone regulation and the ovarian function. And you get to keep your ovarian hormones that are secreting. Um, the drawback with the copper, it just, the copper ones create such a hostile environment. It creates all this irritation, and a lot of women get really, really bad bleeding and spotting with the copper IUD. I am not a fan of those at all. So
Interesting.
no more copper IUD recommendations, Miss Ashley.
Okay, good to know. This is helpful to know. I'm also curious to learn because I have some friends who are my exact age, right around
Mhm.
40, and they're still considering having children. So,
Yeah.
can you tell me the fine line between hormones, IUDs, and wanting to fall pregnant?
Well, and it's interesting is that folks think that if you have an IUD, you can't get pregnant. Well, you take the IUD out, you can get pregnant. But the good news is an IUD has pregnancy protection 5, 7, 8 years, depending on which one you put in. But if you decide during that time you want to get pregnant, just take it out. The good news is your ovaries are still functioning. So you will rather quickly reestablish the normal uterine lining and be able to get pregnant soon. Now, if you're on the birth control pills, the ovaries have to kick back in because you've shut them down. So that may take 3, 6 months for the body to kind of get back to where it needs to go. But eventually the body's going to go where it's supposed to for that age of the patient. But the IUD actually allows things to get started faster because the ovaries are still functioning. So I am also a fan of an IUD in those scenarios, and you can take it out at any point. But it's really an individualized thought. But if, let's say, they don't want to get involved with hormones, then unfortunately you're not left with a lot of choices to deal with heavy periods. Because taking the uterus out if they want to have babies is a no-go, obviously. An ablation would be a no-go because then you're frying the uterine wall, nothing may implant down the road. So you're really left with an IUD, progesterone secreting, or birth control pills, which can be reversible in both cases. Most
Oh,
of the time it is. Yeah.
good. I like that it's
Mhm.
reversible. One of
Mhm.
my other girlfriends, she really wants to have kids and she's in perimenopause and she's taking progesterone. She was taking it every day. I told her to take it on days 14 to 28. If she's trying to get pregnant, should she stop taking progesterone?
Actually, no, you can still continue progesterone when women are getting trying to get pregnant. They shouldn't be on testosterone. But a lot of times we use, excuse me, progesterone to kind of help regulate things and keep things moving. But progesterone itself is not harmful to the baby because also when you think about it, a pregnancy state is a high progesterone state. So often helping them regulate their cycles could potentially help them get pregnant. But most perimenopausal women, I mean, it's a struggle because to get pregnant for many
Yes.
reasons. Yeah, because of the hormonal milieu is not at its optimal. And also a lot of those women are hypothyroid too, which often needs to be addressed, which can affect fertility.
Speaking of weight gain that we were talking a little
Mhm.
bit about
Mhm.
before, can testosterone help us lose weight?
Yes, of course. If you think it helps us process sugar. So when we eat a meal, everything converts to sugar. And it's testosterone's job to take that sugar out of the bloodstream and move it into the muscle so the muscle can use it and burn it clean for energy. So if we're deficient in testosterone, that process doesn't occur effectively. So number one, the pancreas has to use more insulin to deal with it. So it pumps out more insulin, which is why we become pre diabetic in the testosterone deficient state. And then ultimately diabetic because our pancreas just wears out and can't effectively utilize sugar. The other thing is that if insulin's dealing with the sugar versus testosterone moving it into the muscle, it loves to take it and store it as fat right in the midsection where we get that visceral, we call the visceral fat that's really unhealthy for us. That increases our cardiovascular risk too. So testosterone is essential for weight control. When we become deficient in it, we see women moving the weight from their hips and buttocks into the midsection, which is a higher cardiovascular risk state, and that weight to lose from that area becomes almost impossible to lose unless you replace the testosterone,
Mm.
unless you go on semaglutide or Ozempic and tirzepatide to drive it. But a lot of those meds, they muscle waste too. So, and testosterone helps us keep our muscle mass. So
We should probably spend a little bit of time talking about those GLP-1 peptides because I feel like so many people are on them. They're
well,
excited to
who
take
isn't
them.
on those?
Oh, and I just feel like people don't know what they don't know. So, is there any advice or something we should know about these amazing weight loss peptides?
A lot of folks are a little concerned. Well, what are the long term implications of these drugs? Because they've only been out a short period of time. We don't know what are the long term negative potential side effects. Certainly, losing weight will have a lot of positive side effects from sleep apnea, cardiovascular risk, diabetes, and various other things. But there is this concern of long-term safety. The problem is that, as you know, a lot of the side effects can be very, very problematic for patients. Some can be extremely severe with the nausea, the vomiting. You can see bowel slowing down to the point where they get obstructions or they get a lot of gastroesophageal reflux, so that acid reflux, or even severe constipation to the point where they have to disimpact themselves. I mean, so that you have to be really cognizant of those side effects. And some people, they just can't take it. The fatigue can be problematic too, but a lot of folks do really, really well with them. And so it's going to be interesting to see how all the long term data plays out. But even looking at its ability to help with addiction. So a lot of people don't like even drink as much, or they're seeing it helping with patients with addictive kind of personalities, helping with those things and all those benefits. So it's going to be interesting to see how it evolves. But I know I always get a little nervous when they try to claim everything is it's good for everything, including the sliced bread. You know what I mean? It's like
I know.
because ideally we want to be able to use diet and exercise, but some people just don't have the fortitude to do it, or there's genetic predilections that their body doesn't function effectively. But when we're talking about hormones, and when I deal with my patients with weight loss, I'm happy to use those agents. I think they work really, really well. But I always caveat is like we have to get to those root causes of what drove it in the first place. Certainly there can be psychological eating habits and various things, but the two most common is low functioning thyroid and testosterone deficiency in perimenopausal women. We've got to fix those because if we don't, all those drugs are going to take more higher doses, longer to get to the goals. But also, the second they go off of them, they're going to gain the weight all back. So we've got to get to those root bases of cause.
What helps drive down testosterone and thyroid?
Plastics. antibiotics in our food, radiation exposures, all the processed sugars and foods that we eat. I mean, God knows what's in everything. A lot of it comes down to the way we eat here in the United States. I mean, even people don't get gluten sensitivity or celiac in Europe. Our bodies are being environmentally attacked every single day. And these are tiny little endocrine organs, and they're very sensitive to disruption. And when I started this 30 years ago, I would agree with you that they say the average age is around 52, but I'm not seeing that anymore. I'm seeing more like 46 to 48. And I think it's because we have all this crap in our diets and our environment and we have to take some responsibility too, because we've created a lot of addiction to sugars and alcohol and food and various things in our diets. But a lot of us, it's just easier. We eat all these big meals. We go to fast food restaurants. It's just the easy button. And it takes effort to eat healthy and clean and watch all those things. And it's not easy. I mean, I'm an offender of that as well. So,
You bring up a really good point about how menopause is around our 50s and how you're seeing it early and earlier. And
yeah.
I reckon it's going to be even earlier because there's kids today who I've heard there's girls starting their periods at 7 or 9 years old.
It's scary. It's absolutely scary when you think about it, because I see that consistent the breast development and everything in these young girls who are less than 10 years old. And I think about even just not only the physical implications of that, but mental. They don't allow these kids to be kids. And if they're having sexual development of characteristics at that age, I mean, just the objectification in particular of women and young girls. I mean, I think back how we used to tease each other when I was growing up. I mean, even now it's got to be tremendously worse. So I feel for these young girls. And a lot of it, again, is the shit in our diets and the stuff that they put in our food and the antibiotics, and it's not right. So.
Well, and that's why we got to find a practitioner like you to work with.
No, well, I can just fix one small part, but the problem is a lot of times by the time people get to me, a lot of damage is done. And love or hate RFK Jr., I do know that there's a huge focus on our food sources and what's in our food, and I am grateful for that piece of it, because that's got to start at those higher levels too. So,
Yes, I
mhm,
appreciate that.
yeah.
Well, Dr. D, as we wrap up this conversation, it's
Mm.
been so lovely chatting with you,
Oh
but
my
I ask
gosh.
all my guests the same closing question, which is what haven't I asked you that you'd like my listeners to know?
Again, I think I answered it exactly the same last time, but you'll have to go back and look. But just the one thing I always tell people is you know your body's better than anybody else, and trust your gut, trust your instincts. And if you feel like you're not getting the right answers or something that feels and resonates with you, keep seeking answers and do your own research. Don't accept just because someone's a physician or a nurse practitioner, that they're very smart, well-intended people, but not everybody's been properly trained in this. And they may be well-intended, but they may do harm unknowingly to you. So trust your gut, do your research to get the help that you need.
I really appreciate that advice. And I'm going to end with one final story because for doing research for this episode today, I just wanted to see what a regular general practitioner would recommend. So I actually made a doctor appointment because I had a bit of swelling or just like a blocked ear after swimming in the ocean and then traveling. So I went to the doctor to see what he would recommend. And he said antibiotics, first of all. And then he said, is there anything else today? And I said, well, my husband and I are doing long distance. I'm feeling really anxious. I can't really sleep. Sometimes I get really hot at night and I wake up. I get itchy ears besides my ear issue that I'm already experiencing. And he was like, no problem. We can put you on an SSRI, talks me through the
Oh,
SSRIs that are available.
no.
And I was like, okay, I just wanted to see what options were out there. And he wanted to start me on a lower one, which wasn't so intense as maybe Prozac or
Please
Xanax,
don't
but
do this. Please don't do this.
I won't, Dr. D, I won't. But this is the care that women are getting. We go in complaining of these perimenopausal symptoms. And
Yeah.
if you don't know the things that we know, this is how you get treated.
Yep. They get put on antidepressants all the time, and it makes me crazy. Yep.
Yes. Well, Please tell my listeners where they can go to find out more about you.
drhotflash.com, drhotflash.com is our website. And it's undergoing some changes right now. We'll have a brand new whole shell and look in the next couple of months. And one of the things that it's also going to be on that website in the next couple of months is I have a training institute called the Hormonal Health Institute, where we train practitioners to do the type of medicine that I do. And very soon we have probably 5,000 practitioners that we've trained in the last 6 years. So they're going to become certified with us, and we're going to be loading those folks into a database to then be able to have patients search on our website, like who's in our state that's doing this type of medicine that's been trained by me. So that's not on there yet, but know that in the next few months that functionality is coming. So it's a very old school website now, but it's getting a whole brand new look, and that feature, which I think is going to be very, very helpful, because at the very least they'll know that they've gone through the training.
Oh my gosh, that makes me so happy, because I feel like part of my show is like cherry picking, finding people just like you who have your exact expertise. So now that there's going to be a database, that is so wonderful. That's making the world such a better place.
My book is on there, Women's Hormonal Health Institute, or Women's Hormonal Health Survival Guide. A link if you're a medical practitioner and want to learn about our training, there's a link to the thing. So there's some rudimentary things that are still present that are helpful, but the big daddy's coming in that database, I think, is going to be incredibly helpful for our female audience.
Amazing. Oh my goodness. As always, it's been a pleasure, and we'll have you on again soon. Thank you, Dr. D.
Thanks, Ashley.
This podcast is a labor of love, and I'm dedicated to providing free content for years to come. If an episode has brought you joy, clarity, or valuable insights, your support means so much to me. A quick shout out on Instagram or sharing this podcast with a friend can make a big difference. If you're listening on Spotify or Apple Podcasts, a great way to help support the show, or even on YouTube, is by leaving a review. You can also help support my work by using any of the affiliate links that I leave in my detailed show notes, or visit my website, ashleydeeley.com. I'm most active on Instagram if you're looking for me, so you can find me at Ashley_Deeley. Thank you for helping me keep this podcast alive. This podcast is presented for educational and exploratory purposes only. Published content is not intended to be used for diagnosing or treating any illnesses, disease, or disorders. Those responsible for this show disclaim any responsibility for any possible adverse effects from the use of this information presented by myself or my guests. Please consult with your healthcare provider before using any products or services referenced in this podcast. This podcast may contain paid endorsements for products or services. Any third-party materials or content of any third-party site referenced on this show do not necessarily reflect the opinions or standards of the policy of my guests. This podcast and my website, ashleydeeley.com, represent the opinions of myself. The content discussed on the show should not and does not replace medical advice. The content here is for informational purposes only. Episodes on Welcome to Wellness may at times cover sensitive topics, including but not limited to depression, suicide, COVID-19, vaccines, events related to the pandemic, 5G, big pharma, nootropics, circumcision, psychedelics, hormones, the Women's Health Initiative, the use of plants medicine, abortion, geoengineering, terrorism, gender, AI, and sex, drugs, and rock and roll. You are advised to refrain from listening to this podcast if you are likely to be offended or adversely impacted by any of these topics. However, if these topics interest you, you just may have found your tribe. The information or opinions expressed on the Welcome to Wellness show are solely the views of the individuals involved and by no means represent absolute facts, opinions, or expressed by the host, and guests can change at any time. The views of my guests are solely their views, and the Welcome to Wellness show does not accept responsibility for them, and any action you take on the information contained within this show is strictly at your own risk. The Welcome to Wellness host, Ashley Deeley, will not be liable for any losses or damages in connections with the use of this podcast. You should take all necessary steps to ascertain the information you receive from this podcast is correct and has been verified. None of the guests or the contributors on the Welcome to Wellness podcast will be responsible for your use of the information contained therewithin. Under no circumstances will the Welcome to Wellness show or my affiliate partners, suppliers, licenses, or guests appearing on the show be liable for any direct or indirect consequential damages arising from your inability to access this podcast. All intellectual property rights belong to me, Ashley Deeley, and are included but not limited to the copyright and any other rights in the design. You are permitted to the Welcome to Wellness podcast for personal use, but not for commercial use without license. You may not make recordings of or otherwise copy this podcast. If you breach these terms, you lose the right to access the Welcome to Wellness podcast, and you must destroy or return any copies of the recordings you've made. Guests on the Welcome to Wellness podcast may at times provide information on or read extracts from third-party copyrighted work. The Welcome to Wellness podcast does not provide any medical or professional advice advice within these episodes. If you take any action or inaction as a result from the content you consume from within the Welcome to Wellness podcast, this is based solely on your decision, and the Welcome to Wellness podcast and Ashley Deeley and my guests cannot be held responsible or liable for any of the consequences on such action or inaction. Thank you.